Welcome to Bookfulness. This is episode 7 of our deep dive series into Moore's clinically oriented anatomy. In the last episode, we successfully introduced the foundational structure of the upper limb. We focused on its bony skeleton, the humerus, the clavicle, the scapula, and the organizational role of the fascial compartments. That really set the stage for understanding what is arguably one of the most mobile and functionally complex regions in the entire body.
Indeed. And understanding that bony and fascial framework is absolutely essential. It gives us the reference points, the pathways for everything else we're about to get into. The architecture of the shoulder girdle itself, it's a fascinating trade-off, isn't it? Mobility prized over stability.
Absolutely. So our mission today is to continue our deep dive into Chapter 3, specifically covering pages 335 through 373. We're shifting gears now, moving away from that more static framework towards the dynamic contents. We're talking about the complex vessels, the nerves coming off the brachial plexus, and that intricate web of muscles in the pectoral and scapular regions. Our goal really is to synthesize the crucial organizational principles and, importantly, the clinical relevance of this really high-traffic area for you, helping you grasp not just the names, but the functional logic behind it all.
And this material is truly where anatomy clicks with clinical practice. You really start to see it here. We're going to see how the organizational principles of the neurovasculature, how everything is bundled and arranged, directly dictates the pattern of symptoms when something goes wrong, when an injury occurs. If you understand the organizational charts, so to speak, you can often diagnose the location of the damage.
Okay, let's unpack this then. We should probably start with the lifelines of the upper limb, the arterial supply and the return system, the venous drainage. Right, so when tracing the arterial supply of the upper limb, we have this, it seems like a beautifully consistent single main trunk pathway. Can you trace that path for us, starting proximally?
Certainly. The upper limb circulation kicks off just off the great vessels as the subclavian artery. And the name changes, it's important to remember, are purely based on anatomical landmarks. That's a key concept in regional anatomy. So once the subclavian artery passes the lateral border of the first rib, it immediately becomes the axillary artery. This vessel serves the shoulder region, and critically, it's quite vulnerable there in the armpit, the axilla.
And the axillary artery doesn't just run straight through, does it? It's defined by its relationship to a specific muscle in the pectoral region, which actually divides it into 3 distinct parts.
That's a crucial organizational detail, definitely something often tested. The pectoralis minor muscle crosses anteriorly over the artery. And this crossing divides the axillary artery into 3 topographical parts. The first part is proximal to pec minor, the second part is deep to it, and the third part is distal to pec minor. This division helps us remember its branches too. There's nice mnemonic. It gives off 1 branch from the first part, 2 from the second part, and 3 from the third part.
That's a fantastic mnemonic. 1, 2, 3 branching relative to the pectoralis minor. Okay, so following the arterial path distally, what happens next?
Right. So once the axillary artery passes the inferior border of the teres major muscle, that's the defined landmark, it changes its name again. Now it becomes the brachial artery. The brachial artery is the main vessel traveling down the arm, typically located medial to the humerus. It continues down until it reaches the cubital fossa, that pression at the front of the elbow.
And it's at the cubital fossa, then, that the main trunk undergoes its final major division to supply the forearm and hand.
Exactly. Distally, the brachial artery bifurcates. It splits into the radial artery, which runs along the lateral side of the forearm, next to the radius, heading toward the thumb, and the ulnar artery, which runs along the medial side next to the ulna, heading toward the little finger. These are the major arteries supplying the entire distal limb. And we always need to remember that general principle, arteries generally supply the structures they contact. Also, the blood supply to muscles is typically multiple, and it's generally less constant than the nerve supply.
That contrast between arterial and neural consistency is a really core principle from the sources, isn't it? Why is nerve supply so constant and arterial supply so variable?
Well, nerves have to establish a very precise, stable pathway during embryonic development. It's crucial for complex motor and sensory functions to develop correctly. The relationship between a muscle and its motor nerve is pretty much non-negotiable. If that nerve pathway is slightly off, the muscle function is compromised. Arteries, however, they're much more adaptable. The source reminds us that the blood supply to a specific muscle often comes from multiple vessels. It's built-in redundancy. So if one artery is blocked or maybe ligated during surgery, collateral circulation, often through these anastomotic networks around joints, can frequently maintain perfusion. This flexibility makes the arterial map less constant between individuals, whereas the nerve map is incredibly rigid and predictable.
Okay, let's move to the clinical connection, the practical application of knowing this trunk's pathway. Pulse points. Where can we actually feel the pulse to evaluate circulation along the upper limb's arterial pathway? Figure 3.15 shows this, right?
Yes, the ability to palpate pulses is absolutely fundamental. Proximally, although it's not a primary routine site, you can sometimes find the axillary pulse deep in the axilla. More commonly, though, we palpate the brachial pulse in the arm. This is usually done medial to the biceps tendon, just above the elbow. And it's crucial not just for checking distal circulation, but it's also where we listen for sounds when measuring blood pressure, right? Listening for flow through this major vessel.
And distally, the classic site everybody knows.
Ah, yes, the radial pulse, felt at the wrist, just lateral to the flexor carpi radialis tendon. It's the most common site for checking the peripheral pulse rate and rhythm. But we should also mention the ulnar pulse. It's less common to check, but it's located more medially at the wrist. Having these multiple points, brachial, radial, ulnar, allows a sequential assessment of arterial integrity, checking the flow from the arm right down to the hand.
Now let's switch to the return trip. Venous drainage. Just like in the lower limb, we've got two distinct systems, the superficial veins and the deep veins. Let's tackle the superficial system first, as these are the ones often visible just beneath the skin.
Right. The superficial venous system originates from this dense network of small veins in the subcutaneous tissue on the back, the dorsum of the hand. This is called the dorsal venous network. From this network, two major superficial veins ascend the limb. Figure 3.16a shows this quite well.
The first one, ascending along the lateral side, is the cephalic vein. It seems to have the most complicated course as it gets higher up.
It does, yeah. The cephalic vein is the one we often see. It follows the lateral border of the wrist and then the anterolateral surface of the arm. It stays superficial for quite a long way. Proximally, it courses through the delta pectoral groove, that's the natural depression between the deltoid and pectoralis major muscles. It then enters a key anatomical space called the clavipectoral triangle before it pierces the dense, deep fascia, specifically the costocoracoid membrane, to dive deep and join the terminal end of the axillary vein. Its superficial nature and reliable path make it a really common site for vascular access, like 5E lines or PICC lines.
And the other main superficial vein is the basilic vein.
The basilic vein ascends along the medial aspect of the arm. Now, unlike the cephalic, it pierces the deep fascia much lower down, often around the middle of the arm. Then it joins the deep veins, specifically the brachial veins, to help form the axillary vein higher up.
Before these two systems completely merge, they have a really critical connecting point right at the elbow.
That's the median cubital vein. It connects the cephalic vein laterally to the basilic vein medially, passing obliquely across the cubital fossa. Clinically, this is probably the most important superficial vein because the cubital fossa is the preferred, most common site for venipuncture drawing blood or giving AV fluids. Its location is advantageous because the underlying structures, like the brachial artery, are relatively protected by a tough fascial layer called the bicipital aponeurosis. Plus, the vein itself is relatively stable. It doesn't roll too much during elbow movements.
This brings us to that defining anatomical contrast between superficial and deep veins. The sources highlight that superficial veins are external to the deep fascia. What's the functional consequence of that location?
Well, because they're outside the deep fascia, their flow isn't directly assisted by muscle contraction in the same way the deep veins are. They rely heavily on their own internal valves and, crucially, on numerous perforating veins. These perforating veins are like little shunts. They penetrate the deep fascia to direct the superficial blood into the deep venous system. Once the blood is in the deep system, the musculovenous pump can take over and really push the blood centrally towards the heart.
Let's briefly touch on the anatomical naming origin of cephalic and basilic. It can help solidify their locations, right?
Yes, looking at the logic of anatomical naming, which often relates to the embryonic position of the limb, can be helpful. Cephalic suggests toward the head, which fits its lateral position running superiorly up the limb. Basilic refers to the base or foundation, which kind of aligns with its medial position running toward the trunk space. It's a handy mnemonic anyway, to remember which vein is lateral and which is medial.
Okay, now moving internal to the deep fascia, we find the deep venous system. What's their structure like, and why are they named differently?
Deep veins typically occur as paired vessels. They're known as venae committantes, which literally translates to accompanying veins. These paired veins travel right alongside, and they bear the same name as the major arteries they accompany. For instance, you have paired radial veins accompanying the radial artery, and paired ulnar veins with the ulnar artery, as shown in figure 3.1c. This paired structure is actually crucial for the mechanism of the musculovenous pump.
Describe how that musculovenous pump works in the deep system.
Mm-hmm.
It's a really remarkable piece of biological engineering.
It really is. It relies entirely on the interplay between that tough, unyielding deep fascia and the surrounding skeletal muscles. When muscles within a fascial compartment contract, the deep fascia prevents them from bulging outwards too much. This containment causes compression of the deep veins, the venae comitantes, that lie internal to the fascia, nestled amongst the muscles. This compression effectively milks the blood superiorly, squeezing it up towards the heart. It's highly effective because the contraction force is directly applied to these vessels.
But the pump is useless if the blood immediately falls back down when the muscles relax. That's where the critical role of the venous valves comes in.
Absolutely. The venous valves are passive, delicate, cusp-like flaps of endothelium, and they're strategically positioned all along the veins, especially in the limbs. When blood is pushed superiorly by muscle contraction, it flows past the open valves. Then, as the muscles relax and gravity or hydrostatic pressure tries to pull the blood back down, the cusps immediately fill with blood and snap shut, preventing reflux, preventing backflow. This ensures that the flow is strictly unidirectional, moving against gravity towards the heart. It also effectively breaks up those long columns of blood into shorter, manageable segments, which dramatically reduces back pressure and helps prevent things like varicose veins and edema. The efficiency of the whole musculovenous pump system is entirely dependent on having functional valves.
Moving in parallel with the blood vessels, we have the lymphatic system. This is essential for draining excess tissue fluid, the lymph, and returning it to the venous circulation, and also for immune surveillance. How is the lymphatic drainage organized in the upper limb?
It's organized somewhat similarly to the veins, actually. We distinguish two main sets of lymphatic vessels, as shown in figure 3.18. There are superficial lymphatic vessels, which tend to follow the superficial veins, primarily accompanying the cephalic and basilic veins in the subcutaneous tissue. Then there are deep lymphatic vessels, which are far fewer in number, and they accompany the deep arteries and their accompanying veins. Both sets, though, superficial and deep, ultimately drain primarily to one central receiving station, the axillary lymph nodes, located in the armpit.
And the axillary nodes aren't just a simple collection point, are they? They're organized into a pretty strict hierarchy, which is critically important in clinical scenarios, especially in oncology for staging cancer spread.
That hierarchy is absolutely paramount. The sources define 5 main groups of axillary nodes, shown well in figure 3.44. We usually think about the flow. We start with the primary receiving groups. First, the humeral or lateral nodes. These receive most of the lymph drainage directly from the upper limb itself. Second, the pectoral or anterior nodes. These receive lymph mainly from the anterior thoracic wall, including, importantly, the breast. And third, the subscapular or posterior nodes. These drain the posterior thoracic wall and the superficial back region.
Okay, and where do these primary receiving nodes send their output?
They all tend to drain upwards and inwards towards the central nodes. These are nestled deeper within the axillary fat, kind of at the core of the axilla. From the central nodes, the lymph then flows superiorly to the 5th and final group, the apical nodes, which are located right at the very apex of the axilla, tucked up under the clavicle, superior to the pectoralis minor muscle. This hierarchical arrangement means a surgeon, for instance, can often determine the extent of disease spread by systematically sampling these nodes. Checking the central nodes tells them if infection or cancer is spread beyond the primary receiving sites, and checking the apical nodes tells them if the disease is potentially about to exit the armpit entirely.
And once the lymph gets past the apical nodes, what's its final path to rejoin the main circulatory system?
Right, so the efferent vessels leaving those apical nodes merge together to form the subclavian lymphatic trunk. This trunk then drains into the great venous angles at the root of the neck. That's the junction where the internal jugular vein meets the subclavian vein. The specifics depend on the side of the body. On the right side, it usually joins the smaller white lymphatic duct, but on the left side, it typically empties into the termination of the much larger thoracic duct, which, remember, drains lymph from the majority of the body, as shown back in figure 1.27a.
Okay, shifting now from fluid transport to sensation and movement control, cutaneous innervation. We have 2 critical ways of mapping sensation on the skin: dermatomes and peripheral nerve distribution. Let's start with the concept of dermatomes.
Right. Dermatomes give us the segmental pattern of sensation. A dermatome is defined as the area of skin supplied by sensory nerve fibers originating from a single spinal nerve root. Figure 3.19 shows this pattern. Because the upper limb develops embryologically, sort of budding out from the side of the body, the dermatomal pattern maintains a fairly logical cranial to caudal segmental distribution running down the arm. For example, you typically find C5 sensation covering the proximal shoulder and lateral arm, C6 covers the thumb side of the forearm and thumb, C7 covers the middle finger area, C8 the little finger side, and T1 covers the medial aspect of the arm and forearm.
And that pattern is crucial clinically, because if a patient reports numbness or tingling in that distinct band-like distribution, it points directly toward what source of injury.
It points pretty definitively towards a lesion affecting the spinal nerve root itself, or perhaps its dorsal root ganglion. This is often caused by compression, maybe from a herniated intervertebral disc in the neck or some other spinal cord pathology. It indicates a central problem, proximal to where the nerve fibers start mixing together in the brachial plexus.
Now contrast that with the peripheral nerve distribution map, shown in Figure 3.2.
Right. Peripheral cutaneous nerves are different. They often carry sensory fibers that have already mixed and recombined within the brachial plexus, usually deriving input from multiple spinal segments. Table 3.2 details these. So the loss of sensation that corresponds neatly to the mat of a specific named peripheral nerve, like the area supplied only by the axillary nerve over the shoulder, or the area supplied by the lateral cutaneous nerve of the forearm from the musculocutaneous nerve, that indicates a localized injury to that named nerve itself. This could be from something like a deep cut, a fracture causing nerve compression, or even just a localized bruise or contusion happening distal to the plexus.
And while we're on the topic of nerve supply, we absolutely have to mention Hilton's law. It's a key organizational principle for understanding joint innervation.
Yes, Hilton's law. It's a fundamental anatomical maxim, really useful to remember. It states that the articular nerves supplying sensation to a joint often branch from the very same nerves that supply the muscles responsible for moving that joint. Furthermore, these nerves often also supply the skin covering the distal attachments of those same muscles. It's the body's efficient way of bundling function and sensation together. If you move a joint, you are inherently informed about the status of the joint capsule and surrounding structures by the same nerve pathway that's commanding the movement.
The sources mention a slight exception or perhaps a nuance regarding the acromioclavicular AC joint.
That's right. The AC joint, consistent with Hilton's law, does receive articular branches from nerves supplying muscles that act on it, like the lateral pectoral nerve and the axillary nerve. However, it also receives sensory supply from a purely cutaneous nerve, the lateral supraclavicular nerve, which comes from the cervical plexus, not the brachial. This extracutaneous supply is thought to reflect the very superficial nature of the AC joint. Maybe its innervation doesn't need the same deep bundled pathway as a major, deeply buried joint like the hip or knee. It's more exposed, so direct cutaneous feedback makes sense.
Okay, we've established the sensory segmentation via dermatomes. Now let's apply that same segmental logic to muscle function using the concept of myotomes. What exactly is a myotome?
A myotome is defined as all the muscles, or sometimes just parts of muscles, that receive their motor innervation from a single spinal nerve root. Just like dermatomes provide a map for sensation, myotomes provide a map for motor function. They follow a functional, segmental, and sequential organization down the limb, which is incredibly valuable for neurological examination, as illustrated in Figure 3.21.
And this functional organization, going from proximal to distal down the limb, provides a fantastic roadmap for testing motor integrity, doesn't it?
It really does. We observe a very clear flow of primary function as we descend the cervical spinal levels. C5 fibers are primarily responsible for muscles acting at the shoulder, particularly shoulder abduction, like the deltoid and supraspinatus, and also initiating elbow flexion, like the biceps. So we often test C5 by asking the patient to abduct their arm or flex their elbow against resistance. C6 fibers definitely reinforce elbow flexion, but they are also critical for wrist extension. Testing wrist extension against resistance is a common way to check C6 integrity. C7 and C8 fibers primarily shift the focus of function down to the forearm and hand. C7 is the primary segment for elbow extension via the triceps, wrist flexion, and finger extension. C8 handles strong finger flexion, especially the deep flexors. Finally, T1 fibers are almost exclusively dedicated to the small, intrinsic muscles of the hand, responsible for fine motor control like spreading the fingers or opposing the thumb. So you see, if a patient presents with a specific weakness, say they can't extend their elbow properly, you immediately suspect involvement at the C7 level.
This segmental output from the spinal cord needs to be organized and distributed effectively to the muscles. That's the entire purpose of that incredible structure known as the brachial plexus, right?
The brachial plexus is indeed a masterpiece of neuroanatomical organization. It's formed by the anterior ramus, the ventral branches of spinal nerves, C5, C6, C7, C8, and T1. Figure 3.22 shows its complexity. It takes that raw segmental input from the spinal nerves, what we call the roots, and then it shuffles and reorganizes these fibers through several stages: trunks, divisions, cords, and finally it distributes them out into the 5 major terminal nerves that supply the limb. This complex shuffling ensures that muscles with synergistic functions, even if they originated embryologically from different spinal segments, often end up receiving their innervation from the same major peripheral nerve. It bundles functions together.
Can you walk us through the key organizational principle that governs the division stage? This seems to be where the functional segmentation really takes hold.
Yes, the division stage is the crucial functional segregation point within the plexus. The 3 trunks, upper, middle, and lower, each split into an anterior division and a posterior division. And the organizational principle here is crystal clear and really elegant. The nerve fibers that travel through the anterior divisions will ultimately supply the flexors and pronators of the limb, basically, the muscles in the anterior compartments of the arm and forearm. Conversely, the nerve fibers traversing the posterior divisions will ultimately supply the extensors and supinators of the limb, the muscles in the posterior compartments. This design means the body is organized based on action: flexion versus extension, pronation versus supination, not merely based on the initial spinal segment the fibers came from. It groups muscles that work together.
These divisions then recombine differently to form the cords lateral, posterior, and medial, and they're named based on their position relative to a critical anatomical landmark, the second part of the axillary artery.
Exactly. That relationship to the axillary artery is key. The lateral cord is formed by the joining of the anterior divisions of the upper and middle trunks. The posterior cord is unique. It's formed by all 3 posterior divisions from upper, middle, and lower trunks joining together. And the medial cord is simply the continuation of the anterior division of the lower trunk. This intimate relationship with the axillary artery is essential knowledge for surgeons working in the axilla. Any lesion or compression near the artery can potentially compromise all the nerves bundled within a specific cord, leading to very predictable patterns of functional loss downstream.
Let's briefly summarize the general motor and sensory domains of the 5 major terminal nerves that emerge from these cords. Table 3.8 gives a good overview.
Okay, starting laterally from the lateral cord, we get the musculocutaneous nerve. This supplies the powerful flexors in the anterior compartment of the arm, namely the biceps brachialis and coracobrachialis. It then continues as a cutaneous nerve, providing sensation to the lateral side of the forearm. From the posterior cord, we get 2 major nerves. The axillary nerve wraps around the surgical neck of the humerus to supply the deltoid muscle, key for shoulder abduction, and the teres minor muscle, lateral rotation, plus some skin over the deltoid region. Moving centrally, the median nerve is formed by contributions from both the lateral and medial cords. It's the primary nerve of the anterior forearm, supplying most of the flexor and pronator muscles there. Then it continues into the hand to supply the crucial thenar muscles controlling the thumb, and sensation to the lateral palm and digits. The ulnar nerve comes solely from the medial cord. It handles the medial side of the forearm, supplying the flexor carpi ulnaris muscle and the medial half of the flexor digitorum profundus, deep finger flexors. Crucially, it supplies the vast majority of the small intrinsic muscles within the hand, controlling fine finger movements, plus sensation to the medial hand and digits. And finally, the radial nerve. This is the largest branch, originating from the posterior cord. It's the great extensor nerve of the upper limb. It supplies all the extensors and supinators located in the posterior compartments of both the arm, triceps, and the forearm, wrist and finger extensor supinator. It also provides sensation to the posterior aspect of the limb. This comprehensive role is why a simple sign like wrist drop, the inability to extend the wrist or inability to extend the fingers, is immediately highly suspicious for radial nerve damage somewhere along its path.
The clinical relevance here is obviously profound. When injury to the brachial plexus itself or to one of its major branches occurs maybe due to trauma, like a motorcycle accident causing stretching or penetrating wounds or even disease, the resulting patterns of paralysis and anesthesia are highly specific and predictable based on this anatomy.
Absolutely. Injury results in very defined functional loss. And it's important clinically to differentiate between complete versus incomplete paralysis. Complete paralysis means absolutely no movement is detectable when the patient tries to move the affected part against gravity or against resistance. Incomplete paralysis, or paresis, means the muscles are noticeably weak or perform poorly compared to the normal side, but some function, however minimal, remains. And testing for anesthesia, loss of sensation, typically involves determining the ability to feel pain, often using a simple pinprick test across the specific area corresponding to the injured dermatome for root injuries, or the specific cutaneous distribution of the injured peripheral nerve. Because a single peripheral nerve injury often affects muscles derived from multiple myotomes due to the plexus mixing, the resulting pattern of weakness can often be more complex than what you'd see with a simple single spinal nerve root lesion.
Okay, let's transition now to the raw power system, the musculature in the shoulder region. We'll begin with the axio-appendicular muscles. These are the crucial extrinsic muscles that anchor the appendicular skeleton, the limb itself, to the axial skeleton, the trunk. They allow for stable positioning of the shoulder girdle, the scapula, and clavicle.
Exactly. These muscles act primarily on the scapula and clavicle, essentially positioning the foundation, the platform upon which the arm moves. If these muscles fail, the arm loses its stable base, and complex movements become impossible. We typically divide them into anterior and posterior groups based on their location.
Let's review the anterior axio-appendicular muscles first. Figure 3.23 and Table 3.3 detail these. The pectoralis major is the obvious large muscle covering the upper chest.
Yes, the pectoralis major is a large, thick, fan-shaped muscle. It actually has complex actions depending on which fibers contract clavicular head versus sternocostal head. Generally, though, it acts as a powerful flexor, adductor, bringing the arm across the body, and medial rotator of the arm at the glenohumeral joint. Think of pushing motions like a push-up or swimming strokes or even just shaking hands across your body. That's the pec major doing significant work.
And deep to the pectoralis major lies the pectoralis minor.
Right. Pec minor is more of a stabilizing muscle. It attaches superiorly to the coracoid process of the scapula and runs down to attach to the upper ribs, usually 3 to 5. Its main job is to stabilize the scapula by drawing it inferiorly and anteriorly against the thoracic wall. It also helps depress the tip of the shoulder. And as we noted earlier, its position is the key anatomical landmark used to divide the axillary artery into its 3 parts.
We also have the subclavius muscle tucked away under the clavicle.
Yes, a small, almost insignificant-looking muscle running from the first rib up to the inferior surface of the clavicle. But its function is quite crucial for protection. It anchors and depresses the clavicle, helping to resist excessive elevation or dislocation of the sternoclavicular joint, especially during falls onto the shoulder or when forces are transmitted up the limb, like carrying heavy weights.
The last, and perhaps the most functionally famous of this anterior group, is the serratus anterior, often called the boxer's muscle.
It definitely earns that nickname because of its primary, powerful action. Strong protraction of the scapula. That's moving the scapula forward around the rib cage. It attaches to the outer surface of the upper 8 or 9 ribs and then wraps around the thorax laterally to insert along the entire medial border of the scapula on its deep surface. Figure 3.39b and 3.40a show its location. When you throw a punch or reach far forward, the serratus anterior pulls the scapula forward powerfully, increasing your reach. It's also essential for holding the scapula firmly against the thoracic wall, preventing that winging we'll discuss later. Additionally, it works synergistically with the trapezius muscle to upwardly rotate the scapula, which is essential for raising the arm fully overhead, abduction above 90 degrees. And anatomically, its digitations form the medial boundary or wall of the axilla.
Okay, now let's flip around to the back and look at the posterior axio-appendicular muscles covered in Table 3.4. There's a massive superficial layer here dominating the upper back.
That superficial layer is absolutely dominated by 2 huge muscles, the trapezius and the latissimus dorsi. The trapezius is an enormous, flat, triangular, or kite-shaped muscle. It spans from the base of the skull and the ligamentum nuchae down the thoracic spine and extends laterally out to the clavicle and scapula, acromion and spine. Because it's so large and has distinct descending upper, middle, and ascending lower fiber directions, it's incredibly versatile functionally. Figures 3.25, 3.26, and Table 3.5 detail its attachments and actions.
So what are its main roles in moving the scapula? It seems like it does almost everything.
It performs nearly every major scapular movement except protraction. That's serratus anterior's job. The descending upper part elevates the scapula, like when you shrug your shoulders. The middle part retracts the scapula, pulling the shoulder blades together towards the midline. The ascending lower part depresses the scapula. And importantly, the upper and lower parts work together as a force couple to rotate the scapula upward, rotating the glenoid cavity superiorly, which is absolutely essential for allowing full abduction and flexion of the arm overhead. Figure 3.27 illustrates these movements well. It's the key muscle for maintaining postural stability of the entire shoulder girdle.
And next to it, covering the lower back and side, is the massive latissimus dorsi.
Yes, the latissimus dorsi, which means the widest muscle of the back, lives up to its name. It originates from a vast area, the thoracolumbar fascia covering the lower back, the iliac crest of the pelvis, lower ribs, even the inferior angle of the scapula, and all its fibers converge into a flat tendon that twists and attaches near the head of the humerus, in the intertubercular sulcus. It's a potent adductor, bringing the arm down and towards the body, extensor, pulling the arm backward, and medial rotator of the arm. It's the powerhouse for movements like pulling yourself up, chin-ups, rowing, or swimming the curl stroke. Clinically, when you're testing or palpating this muscle, its prominent anterior border becomes clearly visible and palpable.
Yeah.
It actually forms the bulk of the posterior axillary fold when the patient adducts their arm against resistance.
Okay, deep to the trapezius, we find a less prominent but equally vital, deep posterior layer of muscles connecting the spine to the scapula.
Correct. This deep layer comprises the levator scapulae and the rhomboids, major and minor. The levator scapulae runs from the upper cervical vertebrae down to the superior angle of the scapula. As its name suggests, it primarily elevates the scapula and can also assist in downward rotation. The rhomboids, major and minor, often functionally considered as one unit, lie deep to the middle part of the trapezius. They run from the thoracic spinous processes, minor from C7-T1, major from T2-T5, diagonally down to attach to the medial border of the scapula. They are crucial retractors, adductors of the scapula, pulling the scapula medially toward the midline, squaring the shoulders. They also assist the levator scapulae in the downward rotation of the scapula, returning it from an upwardly rotated position. While they are normally covered by the trapezius, the rhomboids become more prominent and sometimes palpable if you ask someone to place their hands on their hips and push backward, which protracts the scapulae slightly, moving the trapezius fibers out of the way. Figure 3.30 shows them well.
Understanding this muscular setup is obviously vital for interpreting the functional consequences of nerve injury. Let's discuss some of the high-yield clinical concepts related to functional loss in this pectoral and posterior shoulder region, as highlighted in the clinical box, pages 367 through 73. The long thoracic nerve injury causing wing scapula is notorious.
Yes, injury to the long thoracic nerve, which arises directly from roots C5, C6, C7 before the plexus really forms, results in paralysis of the powerful serratus anterior muscle. Since the serratus anterior is the primary muscle responsible for holding the medial border of the scapula securely against the thoracic wall, especially during pushing motions, its paralysis leads to the classic sign of a winged scapula.
Can you describe what winged scapula looks like functionally? What does the patient experience?
Functionally, when the patient is asked to perform an action that requires protraction or stabilization against resistance, like pushing against a wall with outstretched hands, the medial border and inferior angle of the affected scapula literally peel away from the posterior thoracic wall and protrude backward, giving it a wing-like appearance. Figure B3.6 shows this clearly. This loss of stabilization means the patient cannot perform strong protraction. They lose power in punching, pushing, or even just reaching forward effectively because the stable foundation for the arm's movement has essentially collapsed. Abduction beyond 90 degrees also becomes very difficult because the scapula can't upwardly rotate properly.
Another key nerve vulnerable in this area is the thoracodorsal nerve, which supplies the latissimus dorsi. What are the clinical consequences if that nerve is injured, maybe during axillary surgery? Figure B3.8.
Damage to the thoracodorsal nerve, a branch of the posterior cord, significantly weakens the latissimus dorsi's functions of adduction, extension, and medial rotation of the arm. Perhaps the most functionally debilitating consequence is the inability to raise the trunk using the upper limbs. Think about climbing a rope, doing pull-ups, or even just pulling yourself out of a swimming pool. These actions heavily rely on the latissimus dorsi. Moreover, it prevents the patient from effectively using an axillary crutch on that side. The latissimus dorsi is essential for actively depressing the scapula and shoulder girdle, which anchors the shoulder to allow weight bearing down through the crutch onto the hand. Without that active depression provided by latissimus dorsi, crutch use becomes very difficult or impossible.
And we should also briefly mention the clinical significance of recognizing muscular agenesis, like Poland syndrome or the consequences of paralysis, and the concept of compensation by opposing muscles.
Right. If a muscle is permanently paralyzed due to nerve injury, or if it's congenitally absent or underdeveloped, agenesis, as sometimes seen in Poland syndrome, figure B3.5, where the pectoralis major or minor might be partially or fully missing, the resulting resting position of the limb or scapula isn't random. It's determined by the unopposed, continuous tonic contraction of the opposing or antagonist muscles. So if the protractors are weak, the retractors will pull the scapula back more. This highlights the delicate, constant balance of muscular tension required just to maintain neutral anatomical alignment. The sources also note that even seemingly isolated nerve injuries, like damage to the accessory nerve, CNS, which supplies the trapezius, can lead to significant functional deficits like a noticeable shoulder droop and marked difficulty in elevating the arm above the horizontal plane, figure B3.7, because the trapezius is so critical for scapular control.
All right, now we move right into the shoulder joint itself, focusing on the scapulohumeral group. These are the 6 intrinsic shoulder muscles that connect the scapula and clavicle directly to the humerus. They are the muscles primarily responsible for producing movement at the glenohumeral joint. Table 3.6 lists them.
Exactly. This group is absolutely essential not just for movement, but for the dynamic stability of this very mobile joint. It includes the large deltoid muscle, the teres major, and then the 4 crucial muscles collectively known as the rotator cuff.
Let's begin with the deltoid, the muscle that really defines the rounded shape of the shoulder.
The deltoid is a thick, powerful, multi-pennate muscle. It has 3 distinct parts based on its origin: a clavicular anterior part, and a acromial middle part, and a spinal posterior part, all converging to insert on the deltoid tuberosity of the humerus. Figure 3.31 shows this arrangement. Its chief role, particularly the strong middle acromial part, is as the prime abductor of the arm, lifting the arm away from the side, typically from about 15 degrees up to 90 degrees or more. However, it needs a critical initial assist. The supraspinatus muscle, one of the rotator cuff muscles, must initiate the first 15 degrees or so of abduction before the deltoid's line of pull becomes effective enough for it to take over the main workload of abduction. Clinically, we test the deltoid simply by asking the patient to abduct their arm against resistance, usually starting from about 15 degrees. This allows us to palpate the firm contraction, especially in the middle part. Figure 3.33 shows this testing.
Okay, next is the teres major. It often seems to work synergistically with the latissimus dorsi, doesn't it?
It does. Functionally, they are often grouped together as medial rotators and adductors. The teres major runs from the inferior angle of the scapula to attach near the latissimus dorsi on the humerus, forming the inferior border of the posterior axilla, as seen in figure 3.34. Its primary actions are adduction, medial rotation, and also extension of the arm. It's an important, although sometimes overlooked, stabilizer of the humeral head, helping to steady it within the shallow glenoid cavity during powerful arm movements, working alongside the rotator cuff.
And here's where we get to the absolute heart of shoulder stability. The rotator cuff, the infamous SH muscles.
Yes, the SH group standing for supraspinatus, infraspinatus, teres minor, and subscapularis. Figure 3.35 shows them beautifully surrounding the humeral head. These 4 muscles arise from different fossae on the scapula, and their tendons converge to form a continuous musculotendinous cuff that completely surrounds the head of the humerus and blends intimately with the fibrous layer of the glenohumeral joint capsule itself, reinforcing it.
Why is this cuff so incredibly important? It seems almost redundant, given the size and power of the deltoid right next door.
It's not redundant at all. It's dynamically essential. The glenohumeral joint, as we said, is a ball and socket joint designed primarily for mobility. This means it sacrifices bony stability for range of motion. The humeral head is relatively large and spherical, but the glenoid cavity of the scapula is quite small, shallow, and pear-shaped. There's very little bony fit. The primary combined function of the SH muscles is to actively grasp or suck the large head of the humerus medially and slightly inferiorly, pulling it firmly against the glenoid cavity during arm movements. Their tonic contraction, their constant low-level background activity, is the key mechanism that maintains the integrity and stability of the joint. It counteracts the strong upward pull of the deltoid muscle during abduction, preventing the humerus from simply riding upward and impinging on the acromion, or even dislocating superiorly. They keep the ball centered in the socket.
Okay, let's quickly detail their specific individual actions, although their combined function is key.
Right. The supraspinatus, located superiorly in the supraspinous fossa, is unique because, as we mentioned, it initiates the first 0 to 15 degrees of abduction. It gets the movement started. The infraspinatus, located posteriorly in the infraspinous fossa, and teres minor, located just below infraspinatus, also posteriorly, are the primary lateral external rotators of the arm. Think about actions like winding up to throw, opening a door, or combing your hair that requires lateral rotation. The subscapularis, which covers the entire anterior costal surface of the scapula and inserts on the lesser tubercle of the humerus, is the primary medial internal rotator of the arm. These muscles don't just act individually, they function together as a coordinated force couple, dynamically adjusting tension to finely tune the position of the humeral head within the glenoid during all complex movements of the shoulder.
And we must highlight that specific innervation difference between the two main lateral rotators, infraspinatus and teres minor. It's a classic anatomical distinction.
Yes, it's a very important distinction, especially clinically. Although both perform lateral rotation and lie adjacent to each other posteriorly, the infraspinatus is supplied by the suprascapular nerve, which arises from the upper trunk of the plexus and also supplies the supraspinatus. However, the teres minor is supplied by the axillary nerve from the posterior cord, the very same nerve that supplies the deltoid. This difference in innervation is the clearest way to distinguish these two muscles functionally if nerve damage is suspected. Injury to the axillary nerve will affect both deltoid and teres minor, while injury to the suprascapular nerve will affect supraspinatus and infraspinatus.
Now, for clinical work, especially examination and guiding procedures like injections, understanding the surface anatomy of this whole pectoral, scapular, and deltoid region is absolutely non-negotiable. What are the key palpable landmarks we should know? Figures 3.36 and 3.37 are helpful here.
Definitely. We can easily palpate many of the bony contours that define this region. Laterally, the greater tubercle of the humerus is usually the most lateral bony point of the shoulder and is easily palpable just deep to the deltoid when the arm is relaxed by the side. It gives that rounded contour to the shoulder. Interestingly, as soon as the arm is abducted past about 90 degrees, the greater tubercle disappears deep beneath the acromion. The lesser tubercle is much harder to find reliably. It's located more anteriorly, generally felt about 1 centimeter lateral to the tip of the coracoid process, which itself is palpable deep in the delta pectoral groove. Looking at the back, the entire spine of the scapula is subcutaneous and easily traced medially from the acromion process all the way to the medial border. We can usually track the medial border of the scapula quite easily, feeling it move as the shoulder girdle protracts and retracts. It typically lies over ribs 3 through 7 when the arm is abducted. The inferior angle of the scapula is often highly visible and easily palpable, especially in thinner individuals. It usually lies opposite the tip of the T7 spinous process when the arm is hanging down by the side, adducted. We can also often observe the clear surface contours created by the muscles themselves, the slope of the trapezius superiorly and medially, and the large distinct muscular bulge of the latissimus dorsi inferolaterally, particularly as it forms that posterior axillary fold. Figure 3.38 shows these contours well.
Okay, let's delve a bit deeper now into some of the critical clinical concepts related to shoulder pathology, drawing again from the clinical box, pages 367, 373. Rotator cuff injuries are incredibly common.
Yes, given the constant work these SSATs muscles do to both move and stabilize the shoulder, it's perhaps unsurprising that their tendons suffer significant wear and tear over a lifetime. The sources consistently indicate that the supraspinatus tendon is by far the most commonly injured or ruptured tendon of the rotator cuff, as depicted in Figure B 3.11. This is often due to chronic degenerative tendinitis, which becomes particularly common in individuals over 50 or those involved in repetitive overhead activities. Repetitive stresses and friction, possibly combined with age-related reduction in blood supply, weaken the tendon, especially as it passes through the relatively narrow subacromial space beneath the coracoacromial arch, formed by the acromion and the coracoacromial ligament. The patient typically presents with pain, especially with overhead activities, and often difficulty initiating abduction. They might try to hike their shoulder using the trapezius to get the arm moving initially. Pain can also occur when lying on the affected shoulder at night.
And that mechanism of passing under the arch leads directly to the concept of painful arc syndrome. How does the subacromial bursa fit into this picture?
Right. The subacromial bursa is a fluid-filled sac located between the supraspinatus tendon and the overlying acromion, coracoacromial ligament, and deltoid muscle. Normally, it provides a crucial frictionless cushion, facilitating the smooth gliding of the supraspinatus tendon beneath that bony and ligamentous coracoacromial arch during arm elevation. However, if there's inflammation of the bursa itself, subacromial bursitis, or degeneration inflammation of the underlying supraspinatus tendon, tendinitis or a partial tear, this can cause friction, irritation, and compression within this already narrow space, especially during movement. Painful arc syndrome is the classic clinical manifestation of this subacromial impingement. The patient experiences pain specifically during the mid-range of active abduction, typically reported somewhere between 50 or 60 degrees up to about 120 or 130 degrees. Figure B 3.34 illustrates this concept.
Why only within that specific range? What's happening biomechanically?
Well, below about 50 degrees of abduction, the greater tubercle of the humerus, where the supraspinatus attaches, and the inflamed structures haven't really significantly entered the narrowest part of the subacromial space yet. As the arm abducts through that mid-range, roughly 50 to 130 degrees, the greater tubercle and the inflamed tendon bursa pass directly underneath the acromion, causing maximum mechanical compression, friction, and resulting pain. Then, often beyond about 130 degrees, the humerus has externally rotated slightly and the greater tubercle clears the anterior edge of the acromion, or the scapula has rotated upwards sufficiently, effectively moving the impinged structures out of the tightest contact zone, and the pain may actually subside or lessen significantly at the very top of the range of motion. This highly specific arc of pain is quite diagnostic for structures being impinged beneath the acromion.
We touched on axillary nerve damage earlier when discussing the brachial plexus cords. How does this injury specifically present clinically at the shoulder joint itself?
The axillary nerve is particularly vulnerable to injury because of its close relationship to the surgical neck of the humerus and the inferior aspect of the glenohumeral joint capsule. It's often injured during anterior dislocations of the shoulder or fractures of the surgical neck. Because the axillary nerve provides the primary motor supply to both the deltoid muscle and the teres minor muscle, injury results in two major functional losses. First, significantly compromised abduction of the arm, especially beyond the initial 15 degrees initiated by supraspinatus, due to deltoid paralysis. This often leads to a visible flattening or atrophy of the natural rounded contour of the shoulder. And second, weakness or loss of lateral external rotation of the arm due to teres minor paralysis. And adhering strictly to Hilton's law, the axillary nerve also provides sensory innervation to the skin over the deltoid region, the regimental badge area, and contributes sensory fibers to the glenohumeral joint and the AC joint. So sensory loss in that specific patch of skin is a key diagnostic sign, and patients might also report diffuse shoulder joint pain.
Finally, let's touch upon an important pediatric injury distinction: the fracture dislocation of the proximal humeral epiphysis. Figure B 3.90 illustrates this.
Yes, this is an absolutely essential differential diagnosis to consider in younger patients, particularly adolescents whose bones are still growing. In a child or adolescent, the epiphyseal plate, the cartilaginous growth plate located between the head and the shaft of the humerus, is mechanically the weakest link in the proximal humerus. It's actually weaker than the strong joint capsule, which is further reinforced by the rotator cuff tendons. Therefore, a significant traumatic force that might cause a true glenohumeral joint dislocation, where the humeral head pops out of the glenoid cavity, in a skeletally mature adult will often instead cause a fracture through the weaker epiphyseal plate in a child or adolescent. The humeral shaft gets displaced relative to the head, but the head itself often remains properly located within the glenoid cavity. The critical clinical distinction is that although the humeral shaft appears displaced, looking like a dislocation radiographically sometimes, the humeral head itself maintains its normal anatomical relationship with the glenoid cavity. Recognizing the patient's age and the inherent vulnerability of the growth plate is absolutely crucial for selecting the correct treatment, often closed reduction and immobilization, and for predicting potential long-term consequences like growth disturbances.
So when we synthesize all this information, the complex neurovasculature pathways, the powerful stabilizing axio-appendicular muscles anchoring the girdle, and the dynamically gripping scapulohumeral muscles controlling the joint, what's the overarching key takeaway about the shoulder's fundamental design principle?
I think the main takeaway is that the shoulder is fundamentally an active machine, not a passive scaffold like some other joints might be. The immense mobility it possesses comes directly at the cost of inherent static stability. The bony fit is poor. Consequently, the structure relies far less on passive elements like strong ligaments and deep bony conformity, and almost entirely on the dynamic, continuous, lifelong engagement of its surrounding musculature. Every single action of the arm, from lifting a cup to throwing a ball, is preceded by and occurs concurrently with complex, highly coordinated stabilization efforts from the S muscles, finely tuning the humeral head position, and the larger axio-appendicular muscles precisely positioning the scapula as a stable platform. The body is essentially engineered a constantly moving, constantly adjusting balance of muscular forces to keep this joint both mobile and functional.
Okay, that's a great summary. So in this deep dive, we covered the complex neurovasculature of the upper limb, including arteries, veins, and lymphatics, and we detailed the numerous muscles of the pectoral and scapular regions that position the shoulder girdle and control the shoulder joint itself.
That's right. And next time, we will delve into the axilla, that critical anatomical armpit region, which serves as the major passageway for all these vital neurovascular structures entering and leaving the limb. Then we'll continue moving distally to examine the specific anatomy of the arm proper, continuing our regional breakdown.
Before we sign off, here's something to think about. We spend a lot of time emphasizing that glenohumeral joint stability relies less on static ligaments and bony fit, and much more on the constant active grip provided by the tonic contraction of those SI's muscles. Given that stability depends so heavily on this continuous, low-level muscular effort exerted by these tendons over an entire lifetime, what are the inherent long-term implications of this demanding design on joint longevity? And perhaps, why is degenerative tendinitis like supraspinatus tears maybe not just bad luck, but almost an inevitable consequence of our human bipedal posture and active lifestyle?
That's a profound point. That constant muscular requirement, that lifelong demand for dynamic stability, inevitably means that mechanical wear, friction, and potentially compromised blood flow within those tendons over decades are virtually guaranteed. It really highlights why conditions like rotator cuff impingement and tears aren't necessarily just accidents, but perhaps better viewed as structural failures resulting from a lifetime of accumulated, necessary muscular debt incurred by this high-mobility joint design.
Food for thought indeed. Thanks for listening to Bookfulness.